And let me start with the World Medical Association, an organization which actually is a little bit older than ASMS, more than 70 years old, but it's not one of the oldest professional organizations. The nurses organization is much older than ours. Actually, it has been founded on September 18th, 1947. And you may know this is just 1 month after the verdicts have been handed down to the Nazi doctors in Nuremberg. There was a Nuremberg trial from 46 to 47. And in August 47, the verdicts were handed down to those convicted in those trials. And certainly, the World Medical Association has been founded under the impression of the war crimes and of the crimes which have been committed in my own country, in Germany, during the Third Reich, the abuse of medicine in experimentation, but also in the Holocaust. And that was why in 45 already, a group of national medical associations decided that they would terminate a previously existing global organization, which was based in France, and to start new. And this was actually at the end of World War II, and this was already decided, and then in 47 it became true, and the World Medical Association was founded in Paris. And since then, the core part of our work is the question on how we as physicians behave, our deontology, the medical ethics. This is certainly the strongest part of our work. I will say a little bit more about that just in a second. Now, our membership is consisting currently of 112 national medical associations, and they are very different, those medical associations. We have basically two big groups, private medical associations, like the New Zealand Medical Association, which is our member. We have, on the other side, statutory bodies, usually under public law, like chambers, orders, or colleges, which combine physicians together. And they are approximately same size, 50-50 in our organization. And within those two groups, there is an overlapping group in the middle that is those who are trade unions. And interestingly, in both groups, in the private medical associations and in those statutory bodies, you have some which are trade unions and others which are not. Classical example is the British Medical Association, you all know as a trade union, and that's in the first place as a trade union. But also a medical association. On the other hand, you have, for instance, the American Medical Association, which is a medical association but is barred from being a trade union. And with the chambers, you have my own organization, the German Medical Association, which is a chamber organization which is barred from being a trade union. And there is a physician trade union in Germany as well, which is partner of ASMS, the Marburger Bund. And then there are other chambers like the Austrian, for instance, which at the same time is also a trade union and does tariff work for their members. So it's a very mixed bag with our membership as well there. And we are probably close to 10 million physicians which are represented through those organizations. I said already, most important is our work on the deontology, on medical ethics, and that's where we really have a leadership, I would say, in this world. But we also look into other things like social medical affairs. One of our recent presidents has been Sir Michael Marmot, and we have for more than 10 years now a very strong focus also on the social determinants of health, which I think are crucially important for thinking about equality in health and fighting inequalities. We cannot stop in just thinking healthcare systems. We have to really look for the social determinants and the ecological determinants, of course, on a wider scale. We do represent physicians to international organizations. That's why we are based close to Geneva. World Health Organization is certainly the most important one, but not the only one. You have others, UNAIDS. But you also have the International Labor Organization, now 100 years old, which deals with occupational health questions, but also wellness issues. We have the International Migration Organization, which more and more has to do and deal with health questions. We have organizations which, in the first place, seem nothing to have to do with health, like International Property Organization or World Trade Organization, which have a lot of effects on health and can have on health. And part you have heard about international trade and commercialization that is going on in this world. We support national medical associations on request. We are very much supporting the idea of self-governance of physicians and try to help with that as good as we can, and we do projects along this line with the different fields there. The organization has a general assembly which meets once a year, and this is the body which takes the decisions on our policy, on what we feel as physician community globally as the medical deontology. It has a council which meets twice a year, which does the interim business, and for the time between the council meetings there's an executive committee which reads on demand, usually once a month by teleconference. And we have committees which do then work on policy and specific problems. Some of the policies which the World Medical Association has made have become kind of historic policies and cornerstone policies for the medical deontology. Immediately after the start in 1947, they started to renovate the Hippocratic Oath, so to speak, with the Declaration of Geneva, which is a revised one, which we have currently again revised in 2017, which got a lot of attention. We are very happy with that, and I would invite you to take a look on that on our website. The Declaration of Helsinki is probably the most important policy when it comes to experimentation in human beings. If you look into the literature, there is no other document that is quoted that often for the research ethics. And it has become part of a lot of international treaties, legislation in many countries. And of course, we are proud of that it got this recognition. On the other hand, an ethical rule that is being turned into a law can constitute a problem. So it's not always good to have too much of that recognition, because once it is a law, it's very difficult for us to change and to work with it. And of course, it has different consequences to the follow-up and to the policing, of course. When I started with the World Medical Association, from my position in Germany in the 90s, I read the Declaration of Tokyo, which basically says, well, doctors should not be involved in torture and degrading human treatment. And I thought, this is an academic thing, you know, this is a thing of the past. And unfortunately, I must say, this is something that now entertains us nearly every day. Because either doctors are part of torture or of degrading treatment, or they are subject of that and being victims of torture or something torture-related process. And that is going on in this world, which I thought would not be true. And you know, this spares out really no part of this world. And we have learned with Guantanamo and with the recent president, there are concerns even in countries which are very solid democracies, and which we always have thought are far away from the idea of torture and degrading treatment. But we have to stay on watch with that, and we have to engage for that. Declaration of Lisbon is a piece of work which very early on we engaged in patient rights and have worded patient rights from our perspective, long before it became politically mainstream. The Declaration of Malta connects directly to the Declaration of Tokyo, and it basically says that doctors should not be involved in force-feeding hunger strikers, especially prisoners. Just to give you an example of our last assembly, I will not run through this, but just to show you the spectrum of what we do is really very wide. We're dealing with generic medical questions, but then we're also dealing with questions which seem to be very remote, like trade agreements. We have been very engaged in the discussion about TTP and TTIP, where we had an extremely critical stance on, because we thought that the healthcare systems which are solidarity-based and which are providing universal health coverage are under threat with those agreements, which does not mean that we are against international trade and fair international trade, but we thought that this was probably not the case with those agreements. And we will have to be on watch again, because those things come back, and what we would like is we would like to really this been done correctly and not in any way endangering our healthcare systems which are solidarity-based, or many of which are solidarity-based. That directly connects to what Martin has just said before. So let me come to the universal health coverage. A new program of work for the World Health Organization has very challenging aims to be reached until 2023. And the World Health Organization wants to have 1 billion more people under universal health coverage in this world. They want to see 1 billion people better protected from health emergencies and 1 billion enjoying better health and well-being, although that is a combination probably of the first two ones. But that is something that they have stated as their program for the next years. That was a 5-year program there. And we have committed ourselves very much to join the work on universal health coverage and the emergency preparedness. Now, it is important to look into what universal health coverage means, because it has several dimensions, and it is important to understand these dimensions for the rollout of universal health coverage. And first, it has a definition of which services are under universal health coverage, and it's very broad. It includes also palliative health services, and they have to be of a sufficient quality to be effective. Second, they have to be open and accessible to all. And third, and this is also extremely important, they should not produce a financial hardship to anyone. This is a progress to some extent, because it really encompasses more health services than we had before. Before we had narrow silos, which the World Health Organization was working with. So this is really a comprehensive view on that. And at the same time, it's more realistic because it acknowledges that health costs money. But it also says that nobody should have any hardship from being seriously ill, and should not fall into a financial catastrophe with that, which we think is extremely important to stress. Now, last year, the Alma Ata Declaration, which you probably know, on primary healthcare got an update, the Astana Declaration. And the Astana Declaration basically repeated what already the Alma Ata Declaration said and rolled out as the role for primary health care, this time including palliative care, which was not in the Alma Ata Declaration before. But it takes a very broad view on what is primary health care. And we believe with WHO that primary health care has to be the core element for a functioning healthcare system. And without that, we believe that universal health coverage cannot roll out. So for us, the Astana Declaration is a core document when it comes to universal health coverage, and it is important to stress that you have to build up primary healthcare systems in order to indeed provide good care. Again, I'm not going into the details of the Astana Declaration, but it's very encompassing, as I said. It also touches questions like the social determinants of health, realizing that health alone, the healthcare system alone, is not the answer for fighting inequities. We have to start much more early, living conditions, social inclusion that we have to have. Investment in education is very important for that. All the things which you probably have already discussed in your country, and I have heard some of that, especially with your indigenous population here, which you have to put a very strong focus on. And that is true for all countries. It's not a problem that you have here in New Zealand. That's a problem which we have in all countries. So Michael Marmot has done a lot of work in showing that these vast differences in life expectancies and morbidity and mortality do not only exist between rich and poor countries, they also exist in a country itself. And he has shown this even for London. And you can do this for Glasgow, and you can do this for my town, Cologne, maybe on a different scale, but you certainly can show that there are the social conditions which determine whether you have good health or not in the end. Now, What we also would like to stress, and this is very important from a physician point of view, is that we agree with the findings that have been made previously, especially Barbara Starfield, who has done a lot of work in this field, that you can show that a good primary healthcare system can deal with the vast majority of cases that come up in healthcare. And that must also include, in the end, at least the basic approach to prevention and palliation. But that is not the end of it. If you structure a healthcare system that is only primary healthcare, then you are producing a dead-end road. So primary care should be the core of a comprehensive healthcare system, and that means, of course, you need secondary and tertiary services, which then can extend the service that has been given to the patients from the primary healthcare system. We also believe that primary healthcare is important for the educational capacities that are provided by secondary and tertiary services. Without that, you probably cannot develop within a primary healthcare system. And of course, it offers perspectives for careers for physicians, but also for careers as patients, because if you are seriously ill and you need secondary and tertiary services, if they are not provided, people go away. And that is what we see in many cases. So we strongly believe that there has to be a development. We would not argue that, of course, it is good to invest your money first into a primary care system if you are starting from the scratch. And we have learned, unfortunately, with the first Ebola crisis some years ago in West Africa, there is basically nothing. So you have to start from the scratch. And yes, you start with primary care, but it is not the end. And in 2008, when WHO made a new policy on primary health care, which I think was a pretty good approach to it, speaking about the core of a healthcare system, of a comprehensive healthcare system, I was utterly disappointed when some of the politicians said, oh yeah, we understood, we built comprehensive primary care. No, that's not the point. The point is primary care is the core of a comprehensive healthcare system. That is very important. Has to be strong, has to be invested in, but it is not a dead-end road and not an end in itself. So the question is, the Istana Declaration is good, we have no doubts, but what is being done with it? And what we hear on the hallways in the World Health Assembly, at the executive board, and from the donors, is unfortunately a little bit a different picture. And they say, oh yeah, what we do is we roll out nurse practitioners and we roll out community health workers. Well, we will come to this in a moment. There are places where there are no physicians, nearly no physicians. Yes, you need community health workers and you need nurses doing work, probably work that extends far beyond nursing. But we think we need also an investment in physicians in all of those countries, not only in the rich countries there. Now, when you look on this graph, which is from 2006, from the World Health Report in 2006, what you can see is on the y-axis the global burden of disease, and on the x-axis the global health workforce. What you can clearly see is that there is a complete mismatch, that you have areas which have a high burden of disease but a very low number of health professionals working with them. And that, of course, constitutes a severe problem, which brings us to the question of how do we fill this? Now, OECD, not a development organization, so it is not an organization speaking for the developing world, but it's mainly affluent countries in the OECD. They come up with a model and say, oh, we have so many well-trained nurses, why don't we let them do the primary care? And they take the clinical lead in this. And Nursing Now says, well, you know, we believe that nurses can be the better primary care physicians, so to speak. That's in an article from Lord Nigel Crisp and Elizabeth Iro. In the end, the quote is, delivery of primary healthcare services by nurses instead of doctors probably leads to similar or better patient health and higher patient satisfaction. And that comes from a study of the Cochrane Library, which has this conclusion. Now, if you are used to read scientific papers, you know what suggests means. In plain English, it means we don't know. And if you look into that paper, you see that nurses have been tasked with single tasks. They have taken much more time. There is not a conclusive evidence for that the outcome is better. Some is a little bit tainted to that. But then the summary and the conclusion for that is you can have nurses being primary care physicians is complete nonsense. I mean, actually, it's a non sequitur. It doesn't provide this information. But that is information which is being widely used by donor organizations, which then are in charge of building up healthcare systems in those countries. And you see there the regions we have: Eastern Mediterranean, Africa, Southeast Asia, Western Pacific, are some of those regions which are depending on help from international bodies. And if you look into the distribution of physicians, you see that the physicians are actually now in the rich countries. That is something which we have to deal with and have to acknowledge. And we have the European countries, New Zealand, Australia, which have a very high number of physicians per population. You have other parts like Southeast Asia, Africa, Latin America in parts, where the number of physicians is very low. And of course, that means they don't get physician services, people there, that we have to keep in mind. Now, what is important is to look into where do physicians come from and how much are healthcare systems relying on physicians from the outside. And unfortunately, your country, New Zealand, is one of the record holders here. You are the second after Israel. Israel has nearly 60% of the physicians coming from other countries or being qualified in other countries. New Zealand, over 40%. So you are relying very much on educational capacity that is produced in other countries. Yes, of course, you are an immigrant country, that is true, but that is an extremely high number, and especially for rich countries. There are others like Norway, which come pretty close to that, although I should say, to be fair, Norway pays for that. So when they send out their students, they also pay for their students, which is very important to know. But you are within this very high group, and this has something to do with the chances for healthcare in other countries, and that is what I would like to make you aware of. So we have this movement of physicians in this world, which is a movement from east to west, from Eastern European, from Asian countries to Europe, but also to the United States and to Canada, which are net recipients, very strong net recipients of especially physicians in there. You also have a movement from the south to north, and well, to be quite frank, it's a movement along the money gradient. You know, it's from poor to rich. That's what it basically is there. So south-north, and you also have a movement into Australia, into New Zealand, what we have seen in the statistics before, and also between New Zealand and Australia. I think you all know this phenomenon which we have. Again, money gradient is the term here, which plays a role. To that extent, you are on the wrong side of the earth. So you belong more to the north. You're messing up my scheme here a little bit, sorry. And then there is a specific phenomenon that is the export of doctors from Cuba. Doctors seem to have kind of a huge production line to produce doctors, and they're exporting them to African countries, but under very, very questionable circumstances. And this is a model that is more than questionable, and to me it really comes to modern slavery that has been done, because those doctors are not being paid. Those doctors get a pocket money from Cuba, and the money is paid from governments to the Cuban government. So a very questionable model that we have there, also of a questionable quality at some points. The Health Report 2006 gave an overview. Unfortunately, I don't know of a more recent one from Africa, asking doctors from Africa, why would you relocate and why would you leave? And yes, indeed, the better remuneration, so a better payment, is certainly the one which got the most positive answers. But it's immediately followed by others like safe environment, living conditions, lack of facilities, which means lack of healthcare facilities in there. Lack of promotion, so no career that you can build up in your system that you have, no future, heavy workload. So a lot of things which directly relate to the work environment and how can you work in your system, what can you do, what can you provide. And if you think of it, just taking a step back, is we had these siloed programs of help for Africa. Basically in Africa that was HIV/AIDS, tuberculosis, river blindness, malaria, where organizations were involved in, humanitarian organizations were involved in, UN agencies were involved in, certainly good work that has to be done and important work that has been done. But unfortunately, the people in Africa, they are so nasty, they get a heart infarct, they break their legs. They have musculoskeletal diseases as anybody else. So if you are a patient in one of those countries and have all those things and are not being saved by one of those programs, what do? If you can afford it and you are so lucky to do so, you go away. You go to another country. You go to India, you go to Europe or to America in order to get treatment if you can afford it. Only very few can, I know. But the same is true for doctors. If you are a physician in such a country and you may be hired and have the luck to be hired by one of those siloed programs, you are lucky. But otherwise, your chances to be able to help patients who are seriously ill is extremely limited. So what do? You go away. Get a better future for yourself, for your family, but also have a chance to do something real for your patients. So the development of those healthcare systems, in a sense of universal health coverage, to really build up a broad healthcare system that is solid and sustainable, is extremely important, and we have to convert from the siloed thinking of delivering support and help into the universal health coverage. And again, let me come back. Why is it so important for us here to think about this? Is because we are taking up a lot of the health professionals from other countries. Now you would say, well, my colleague is coming from abroad. Yes, but he is coming from Great Britain, he's coming from Germany, he's coming from France. So why should I care? Does it have anything to do with us here, which we have a system here in New Zealand very close to what I would call universal health coverage? Yes, it does have to do something with that. First, let me say it has not changed over the past years since we know this problem. Actually, there are a few countries which are pretty stable and doing a little bit better. The United States is one of those countries which has been very stable in importing physicians. I think the UK has speed up some efforts in order to produce their own physicians much better than they did before. But for most other countries, this is still a steady incline, including my own country, Germany here, which the bottom line here is one of the low ones, but still it's also an importer of physicians from other countries. Now, where are those physicians coming from? They are coming from, to a large extent, and this is the bad news, they are to a large extent coming from poor countries in Africa, the Caribbean, Mexico, for instance, here, and from Asia. And those are the ones going into the United States. In the United Kingdom, that's a similar picture. We import a lot of the workforce into our countries from poor countries which actually would need those physicians which they have on. So to get the numbers right, think of it like you have, I have to have my cheat sheet here. You have in New Zealand about 2.9 doctors per 1,000. We have in Germany 4.1 per 1,000. You have in the United States 2.6, in the UK 2.8 per 1,000. In Malawi or in Tanzania, you have 0.02 per 1,000, which means to Japan or the United States, that's 100-fold difference. To some parts of Europe, that's a 200-fold difference. That does not only mean that your chances of being seen by a doctor if you're living in such a country is 200-fold less likely, it also means something different. It means if a country of approximately equal size in the rich part of this world tries to satisfy its needs of, let's say, a shortage of just 1% by importing from an equal-sized country in that situation in Africa, it means you basically would have to take up the whole workforce from that country into your country. And that leads to jokes like saying that probably there are more Malawi physicians in Birmingham than in Malawi. And there is some truth to it. So we are depleting the physician workforce from this part of the world. It's not your fault, but it's something that is happening. And we have to look into that. And if we are really talking about universal health coverage and rolling it out to other countries, we have to be aware of that. So this is the problem which we are discussing. It's the immigration into the health workforce and the emigration from the health workforce, which ideally is balanced, but in many countries is not. And we have the poor countries where the immigration is higher, and we have the richer countries where the immigration is higher. And yes, this is something that has been addressed. Some countries have made up rules to reduce the number of doctors they import from poor countries. Whether that works or not is a completely different question. But most of the rules, including the charter by the World Health Organization in trying to limit this process of importation, unfortunately don't work. As you have seen before, the numbers are still increasing of the immigration. But, and this finally brings me to your role as a trade union, as a physician trade union. We are always looking on this spatial migration here, which of course is important, but there is something else which probably is much more important in order to put this stimulus for being a pull factor, pulling doctors into your country. And this is what I call the social migration. Because what we see in many countries is that we have more early retirements, we have more parental leave. That's not only a problem which is produced by female doctors, that is true for male doctors as well. We have a demand for a reduced work time. Doctors are no longer the single income bringer for one family. We have usually spouses which have ambitions in their profession as well, maybe as doctors, as nurses, as other professionals. And that brings with all of us the fact that we do not want to work 80 hours anymore per week, but having a regulated work time. And I think that's fair to ask for that. We have doctors going into other occupations because some of us are sick and tired of doing this. Sometimes we have wrong incentives to take out physicians from physician work into other occupations. And we do not always have enough force on education and re-entry. Many of our countries are under-educating the health workforce, so they are not producing enough doctors. And very often we do not have enough incentives and enough help, for instance, for re-entry, for instance, after parental leave into the workforce. But again, think of it like this. A small change in the workforce, and this is producing actually large changes here, not small changes. A small change can already have a devastating effect on poor countries, and that in sum is what we are doing. So when you are working as a trade union for your work conditions to make the work as a physician attractive in your country, this is important not only for yourself. This is important for the global balance which we have, and not for stealing physicians from other countries, not to produce this brain drain which is going on. Instead, what we need is, we need better working conditions, not only here, but also in those countries where those physicians are coming from, giving them a perspective into a system that is not only a minimum primary care, that is what we have experienced after Alma Ata, the first declaration in 78, you know, I'm exaggerating, helping with Band-Aids and aspirin was it. But this very limited, restricted model of primary care doesn't help. You have to develop healthcare systems. Yes, again, I know this is difficult in many places, but if we stop the aspiration in the first place, it never ever will happen. And therefore we say we have to work on this in all places in this world and not only in the rich parts. So let me conclude. So we wholeheartedly support the idea of universal health coverage. We think that is a model that should be rolled out. You are blessed, like with a few other countries, to have a model that is pretty close to universal health coverage. There is probably no model in the world which is complete, let me say that. So all models have some deficiencies and some shortcomings. But there are countries, yours is one, most of the European countries are those countries which have models which are pretty close to universal health coverage and are pretty equitable, not perfect, by no means, but pretty good. But there are many countries in this world which have nothing that comes close to that. And that is something which we have to do. And by the way, this is also the best insurance for having a good emergency preparedness. The Ebola crisis, which we have now in the Congo, which we had before in West Africa, proves this. Having a healthcare system is crucially important also to deal with emergencies. And the health workforce, as I said, is not only determined by this cross-border migration which we have, the spatial migration which we have, we also have to think about having incentives to stay in the workforce and not asking for early retirement, like in my country. You know, previously you had to carry doctors out of their office when they were 70, 75, and found some deficiencies. Not with all, but you sometimes really had to give them a push and say, it's good now. The problem now is they come and say, they are 60, can I have my pension? You know, because they're getting sick and tired of the bureaucratic work they have, of the political intrusion into the system, of politicians telling them what they have to do, of administrators telling them have to do what they have to do, and they say, it's enough now, I take a smaller pension, but I go. And these are forces which are much stronger than just the spatial migration, because they trigger a spatial migration, which we have to keep in mind. So we have to deal with those questions, and we have to get better on that. And as I said, it's not only for the poor countries. This is a job which we in the rich countries, and let me speak now as a person coming from an affluent countries, which we have to do in the first place. And we have to keep in mind that when we err and when we do wrong, we produce a damage in our countries, we produce an even bigger damage in the poor countries of this world. Thank you for your attention.
Let that kind of, a lot of those sobering thoughts sink in as we get to our panel. Kia ora, Otmar. That is a really important talk. And I think it leads us well into this next little phase, which is a sort of a back and forth panel discussion where I'm sure we can unpack some of the high level issues which you've outlined to us today. So to that end, can I ask our panellists to come up? We've got Dr. Tanya Wilton, who's ASMS branch vice president at Hutt Valley and an emergency physician at Hutt Valley. Kia ora, Tanya. And the other panel member this afternoon is Dr. Jeff Brown, who's a paediatrician at the Maiti Te Papuoia, Palmerston North, our clinical executive for Te Urupa Harakeke, the Women and Children's Cluster at our place, and also needs no introduction as a former and long-serving ASMS National President. In fact, I think, Jeff, you were National President for longer than I've been a doctor. So look, it's with great pleasure that I welcome panelists. A warm round of applause to welcome our panellists. And then, Look, I guess if I may, well, can I take the chair's prerogative, please, just to kick off with maybe the first question. First, a very slight defence. New Zealand, our international medical workforce has come down in the last 3 years, and in 2017 we were down to 40% and shedding about 0.4% a year. We may even be under 39%, but I don't think that solves some of the big issues that you've had. And I think the big change there has probably been an increased number of medical school graduate outputs here, and I dare say hopefully retaining some more of our own, therefore with the less need to import nonetheless. So look, my question is, I guess, starting with the World Medical Association work, what do you see as sort of the biggest challenge to that kind of global collective medical action in this day and age?
What we think on a global scale is, of course, the misunderstanding, which is still predominant, that health is an expense. I think the most important change in thinking that we have to have, and unfortunately that would demand a big change for some of the politicians and a big change for some of the economists, is to understand that health really is an investment that has been made. And this is something which is on the global scale the biggest challenge which we have before us, to have this understanding. We are very happy that we have the support of some of the governments, especially the Japan government, which has understood that exporting their ideas of universal health coverage is actually better than continuing working in silos in the international help. And when we had this meeting in Tokyo, one of the keynote speakers was the finance minister, explaining his engagement to convince other finance ministers to make investment in health and not thinking of an expense that we have. When we think about physicians, there is still some work which we have to do with colleagues, because there are enough colleagues who think that universal health coverage is a communist idea and has only negative consequences for them. I think we have enough examples now from this world in Europe, in Japan, in your country, where you can say this is not only better for our patients, it's also better for the doctors themselves. Because I think you can make a good living with a good healthcare system, and you get a much better satisfaction in your work than only serving a few rich people in your countries. So this is work which we also do. Unfortunately, that is going quite well, I must say. I think we get more and more support from all the medical associations around the world to do that. And to fight a rumor that is very often being spread is the American Medical Association has signed up to that idea a long time ago. Although they have some problems with the ideas of a single payer, but they have no problem with the idea of universal health coverage, including the fact that nobody should suffer financially from getting the health care he or she needs.
Good. That's a bit of good news for our American colleague over there. Go the AMA. Now, are there microphones around the room? Because I think I've got... introduction from our panel members first and a bit of an opening gambit.
Hello, and lovely to be here. I feel somewhat overawed by the company I'm keeping today with our very impressive speakers, and also with all of my colleagues here who I know work really hard and give of their all in fighting for the public health system. So I feel somewhat humbled. I'm an emergency physician, so I guess I feel like I'm on the cusp of primary care and secondary care, and that kind of unenviable gap that lots of our patients fall into. And I'm really interested to hear what you had to say, Otmar, about the universal health coverage. And I agree that we have a fantastically good system on the whole here in New Zealand, but we still have primary care is privatised in our system. And, you know, there are people who that is a massive barrier for them accessing primary care, and I see that every day at work. And I'm not very good at addressing the hows, but I think we need to acknowledge that that is an issue and think about how we might be creative about overcoming that barrier for many of our people in our country. The medical migration, my goodness. I feel slightly guilty about this because, it's such a conflicting area to be in. We all feel like we're under-resourced and we're under the pump, and an extra pair of hands would be like manna from heaven, I guess, a lot of the time. But, personally, I don't think, who else am I depriving of medical care when I get that extra pair of hands into my emergency department? So I think that's a good thing to think about. And I know that I don't know where we lie on the net immigration front, because definitely it's kind of depressing when people do leave, either for usually Australia or sometimes North America. But also I wondered whether we have a medical migration from public system into private medicine as well. And I know very good colleagues who, have done their darndest to stay in the public system, but that the conditions have, they just get a sense of control, a sense that things are better if they do their one day in private. And, that's really, I find that quite disappointing. And how can we look at maintaining the conditions in the public system so that people don't feel the need that that's what they need to do to have that sense of control, to not be beholden to 15 reports or reviews or those kind of situations where you have a good idea and you can go with it and do what you want to do without people kind of coming down hard on you. And I did hear this week also an interesting concept about climate change apartheid, that also, we are going to be I guess benefiting from people escaping climate change phenomena as well, and trying to think of how that sits with us as well. That's probably enough from me. And it's good to see, the last time I saw Jeff we were fortunate enough to be in Belgium, and I'm glad we've coordinated our wardrobes again today with, oh no, I'm not wearing my red trousers, that was yesterday. Red scarf, but we were both in red trousers in Belgium, so it's good to know the Kiwi fashion sense is holding its own in Europe.
I wouldn't want you to be a representative of Kiwi fashion necessarily, Jeff. Anyway, so
He's just jealous.
I am jealous.
Kia ora koutou. I'd like to, just before coming on to what Otmar's talked about, reflect with a small whakatauki, he kotuku rararenga tahi. The white heron only flies once. This is a very special occasion, and I know others, including Murray, have said this, but as the president who worked for Ian or with Ian or under Ian, or however you might like to look at it, for a third of his time with ASMS, I would like just to take this occasion to recognise how fantastic his contribution to the public health system in New Zealand has been, and give my personal thanks for that. Some tough times together, but a really strong fight. And it's only when you work with a man like that you realise how much he does behind the scenes and how he truly has influenced where we are today. So, tēnā koe, Ian. And Otmar, thank you for that incredible presentation. I just want to underline three things that that resonated with me out of all that good work. One is that retention. Our union has fought to improve working conditions and continues to do that. And it always worries me that in doing that we might be also attracting and stealing other doctors from where they should or could be working. The chair of the Medical Council pointed out to me that having a very big mortgage and a second wife would be one way of keeping you in the workforce for longer, but I'm not offering that as a solution, Curtis, even though you did. But the slide that you put up from 2006, the reasons to migrate as a doctor, that was sort of the list that we have gone through continually as ASMS as why New Zealand doctors leave for Australia. Yeah. It's the same list. Yeah. So I'm really struggling with how we can both improve our working conditions for doctors in New Zealand and not have a counterbalancing or a bad effect somewhere else. And I have heard it said by people in very high circles that manage our health system that if we just dumbed down our training and made it that our doctors couldn't get a job anywhere else, that would be the great solution. But believe me, other countries very close to us in the Pacific are doing exactly that. So we laugh about it, but it is a technique being used by health administrators in governments in our part of the world. The second thing that I also struggle with is, are we perceived, ASMS, as a union fighting for a public hospital system or a public health system? And you made the point in your presentation about universal health coverage and the core being a primary health system. If we ignore that, then we end up with them and us. We end up with different organisations fighting each other for primacy. How can we be an arguer for a public hospital system of the highest quality or of sufficiently high quality in New Zealand, as well as being what we promote ourselves as, the advocates of a very strong public health system? So that's a challenge for this union. The third thing that you mentioned was the social determinants of health. Equity, the rich-poor divide, both between countries, within countries, and within even cities. As a paediatrician, it has been put to me that why do we tolerate it's embargoed until 9 o'clock tomorrow morning, but I'm going to tell you anyway. The latest epidemiology for children dying shows that if you're a poor kid, you're 3 times more likely to die last year in New Zealand than if you're a rich kid. Can we tolerate that? Can I still get up and go to work as a paediatrician knowing that's happening? If I turn it the other way around, for every rich kid that dies, 3 poor kids die with her. Ouch. So how can this union increase its focus on equity? I'm absolutely impressed that at our 30th birthday, we opened with a mihi whakatau. We opened with you, Curtis, to keep us culturally more competent, but are we culturally safe? This organisation, are we sufficiently apprised of kaupapa Māori? Do we honour te turiti? Do we acknowledge our own unconscious as well as conscious biases? And are we true to our gifted name, Toi Mata Haora, as much as we should be? I just lay down that wero.
Kia ora. Jeff, I can see you were listening at our Cultural Competence Symposium on Tuesday from Medical Council in Te Ora, so that's a good wero to lay down, a good take or issue to lay down for us. Look, I think there's been so much discussed and opened up with here. I'm sure there's some questions from the audience. I don't know where the microphones are, but there's one over there. So throw them at the panel and let's hear their awesome answers. Kia ora.
I think what you were saying about, sorry, Siobhan Cross from Christchurch. I think what you were saying about sort of net migration, you can't, well, it is very difficult to take away the choice of an individual doctor, unless you're in Cuba, obviously. And so surely it is that the same things that are going to improve both systems is improving the social circumstances back at home, because although remuneration sits high, once remuneration can cover the living expenses of your family, many people don't want to leave just to get paid more and more money. They like their homes. But surely it's the social situations that they're living in and the safety of their families and their ability to care for their patients within their healthcare systems that makes more of an issue rather than necessarily wanting to be in New Zealand or the UK or America.
Was there a question in that one there? So, sorry. There's very much an implied question.
I guess the implied question is there a role that we can have in, we can't advocate, well, any more than anyone else for the social circumstances, but we can advocate for the medical circumstances because it's demoralising being a doctor when you can't fix your patients because you don't have even the basic facilities to do so.
Yeah, just a short answer. This was a comment more than a question there. But quite clearly, there is a role for you. And to come back to your point, really, are we incentivizing more people to come to New Zealand when we are improving our working conditions? Yes, you do. But at the same time, you know, for each year, you keep a colleague longer on the work role, you know, because he is satisfied with the work he can do, and provided he still does it correctly, but let's say that that is the case for many of our folks who are now retiring early. For each one you can keep there for a year, you have saved a physician from going away from a poor part in the world. So it is important to have good working conditions, and it's not only an egoistic drive you have there to do this for yourself. It is important to stabilize the system and really to have a healthcare system that can retain and build resilience within that, the system. So yes, improving the conditions is very important, and yes, you're also right. Migration, the money gradient is there, is a fact, but what incentivizes the individual physicians is also these other points which I have mentioned there. It is working conditions you have, also living conditions for your family. And I myself have been structuring an immigration program in the 90s from Germany to Scandinavia, because my organization thought we have an oversupply of physicians in Germany at that time, which actually was never the case, but they didn't believe me. The doctors who came there and wanted to be part of this program, and they were looking for specialists to go, none of them was unemployed. They all had tenure-track positions. And so I asked them, why do you want to go to Scandinavia? You know, you will be in a far remote location. It will be dark half a year. And yes,
a bit
you
like Palmerston North.
You may it's nasty. and yeah, you may have a little bit higher salary, but you pay way more taxes, and everything is more expensive, so you don't have more money. And they say, we know. But, you know, we want to have better working conditions. You know, we want to have time to deal with our patients, to do our work, and not just doing paperwork 90% of the time instead of dealing with patients. So these are good reasons for people to go. So working conditions are important.
I'm just going to trust the microphone's going to get to the right people, and they're going to yell their question out, and the right person here is going to answer it.
Kia ora koutou, ko Cochrane tōku ingoa no tuanga nui a Kiwa, haura taira whiti aho, Cochrane paediatrician from Gisborne. I want to make a comment and potentially lay a challenge for us as specialists and as a union. For me, there is definite room for improvement for working conditions, but does that need to be a contraindication for us to be advocates in determinants of health? Because day to day, I see so much determinants of health outcomes in my patients that's out of my control in the clinical setting. And that is a source of dissatisfaction and stress for me at work. And could we not work on both and have support for each other and from the union to work on both with the actual physical working conditions that we have, as well as doing all the other wider universal healthcare, health promotion, the primordial health prevention stuff?
This is not a glib response, noting one of the positions I hold, but at least what ASMS has done over the years is been able to protect special leave and ability to go and work with bodies and organisations such as the colleges that can fight for those very things. That not just the things that are core to the union, but actually allow you to do other things in your job and be given leave for it and be supported in it. So I'm hugely proud that this union has fought for that ability so that we can go and argue for better social outcomes, better housing, and do some campaigning, which is really looking at the upstream determinants.
Hello, I'm Dara de las Heras, gastroenterologist from Waikato, DHB. I was wondering what you thought about the role of technology supporting doctors locally, so that, you know, I guess there was always this kind of aid going to poor countries to save them from, you know, dying and things like that. But in the world of new technology, how do you see the role of, you know, supporting local doctors so they don't feel they have to leave their country?
I think that is a very good point, and some countries have been doing quite well with that. Thailand is one of the countries which has very early embraced the idea of doing a leapfrog development rather than going technology step by step. And yes, I think that is something that will help in many circumstances, not only for the physicians, also to the patients directly, to better deal with their own health issues. Will it replace physicians? No, not at all. I don't think so. There was a lot of talk at the Istana conference last year, where people were saying, you know, technology, artificial intelligence will replace radiologists, for instance. I think those are people who do not know what radiologists do. And they're producing oracles. So this is not the case. Yes, there will be a lot of help, and there is a lot of modern technology which can be deployed in field, which would require that, for instance, networking, I mean technical networking, gets better. But that is something that is actually being done, it is underway, and will certainly help to a large extent. But again, it will not change the fact that we have big problems with the social determinants of health, number one. Number two, it will not replace the physician competence. So you cannot say, well, we produce a lot of technology, we have artificial intelligence to read ultrasounds and lab testings and some types of x-rays. Yes, that helps, but it does not replace the arbitrary work that physicians do in the end, you know, the intellectual capacity, and it does not replace your social capacity, which may be even more important in the future than what we have now. So that is something which you cannot replace, and probably should not be replaced. And if you look into the history of rationalization in industry, what will be replaced is the lowest grade job first, not the highest grade one. That never has happened, and probably will not happen in the future. So yes, our work will change, our means will change, our possibilities will improve with that, especially also in poor countries. But the problems still will remain with that. So they have to still be addressed. Physicians have to be the social determinants of health have to be addressed as well. We have been doing a lot of work in the education for physicians for multi-drug resistant tuberculosis. And I had a chance to be in many of those places where tuberculosis is extremely high. And when you see the slums in Africa or in Latin America where you have these problems, I mean, you immediately know you can pour in as many antibiotics you have in this world. This problem will not be solved until the housing problem is solved. You know, people need decent housing, they need decent food and education for that, and then you can solve this problem. And that, by the way, is in how our societies, in the affluent societies, the tuberculosis vanished. It didn't vanish because we had all the antibiotics. It vanished because our living standards became better. And that is the same thing we have to do in those countries. And let me answer one not asked question, but I make it a question. What can you do as physicians concerning the social determinants of health? You can engage in your local community to make sure that housing conditions improve, that education improves. You can, as a physician, talk to parents who are bringing their toddler and having a cigarette in their hand. You can talk to mothers not to drink while they are pregnant. You can talk to parents to read their children a story at night, which is, by the way, the only way to enhance their intellectual capacities, which we know of. So there are ways we can work with that. Social determinants of health will not be changed through the healthcare system alone, not at all, not even in a significant way. But we as physicians can engage and can do something.
That's inspiring. Aaron George, another review.
Yeah, just radiologist from Wellington. Just on the topic of AI, I think AI is about working with machines, so any of you investing in the share market, please do, because including radiologists, we're all investing in it. So just about global migration, I think it's actually not a bad thing. It's actually been seen quite positively in many countries, because what it does is it actually sets the bar quite different to what people are used to in places. So especially if you look at the Asian part of the world, and you look at incomes between Asia and Europe, for example, now, specialists are actually earning similar amount of money. And they said, oh, this is going to mean there is going to be a reverse migration. And that did not really happen. You know, it started and then it stopped. And the only people who moved back were people who could not become specialists in Europe. So North America, Australasia are different. But what in this process has actually happened is people have now started looking at what else is possible, what kind of healthcare is available. There's predominant focus on primary healthcare, and that is now moving to secondary and tertiary healthcare. There is also universal healthcare provision, which is being discussed between some countries and countries where it already exists. So I think there is no need to feel bad about global migration. Competition is part of life, and I think it is just about using it in the right way rather than thinking, actually, are we taking away? Because that is just, that is just the way the world is. And it is just even between places in Asia, people are moving left, right, and center. So just my take on it, having moved 4 or 5 places before coming here.
That's a starter for 10.
No, but I don't agree with that to say just that's the way the world works. I mean, if we accept that, then nothing gets better. No, yeah, but no, we have to work on those problems. And yes, I have migrated myself. I'm working in a different country. I've been working in several countries during my lifetime, so I have this experience myself. And the organization I represent, the World Medical Association, is clearly in favor for the freedom of migration of health professionals, and we think that exchange is necessary and useful, but it should be balanced in the end, and it should not be at the expense of the poor nations. That is very important to us. And we, by the way, we fight models of civil conscription. There are countries which say if you are being educated as a specialist, you have to work a number of years in our country in order to make good for that. We fight these models. We think it is completely unfair to have bonding restrictions or civil conscriptions on one profession alone. If you have a model for this for the whole country, that may be something different for everybody, but it's only for physicians. We fight this, and we think that is completely unfair. So migration is important, migration is necessary, but it must be balanced.
It was represented to me by somebody who lives in metaphors that we don't blindly use medicines or treatments without knowing both the benefits and the consequences. And so medical migration should be no different. We should be aware of the benefits and the consequences.
Exactly.
We were speaking before about clinicians in high-level positions. Kevin Snee.
Thank you. So I'm Kevin Snee. I'm the Chief Exec at Hawke's Bay District Health Board and soon to be coming to Waikato, so I'm looking forward to that. My original trade was as a public health physician, and you've kind of partly answered my question I was going to ask, but I just wanted to make a point. DHBs are in most parts of New Zealand, are the biggest employer. We're about 10% of local GDP. We've got the most critical mass of, in most parts of New Zealand, of any public organisation. So as a force for good in terms of addressing issues of inequity, DHBs are really powerful, and they generally, in my experience, don't live up to their potential. But what you're highlighting, Jeff, is, and Otmar and the panel in general, is the potential that we could have as DHBs working with SMOs as powerful advocates for change and powerful advocates for addressing inequity. And you've given a number of powerful examples, Otmar, about what you could do. And I guess I'm just wondering whether ASMS would work with the DHBs to actually help SMOs to fulfill that potential.
Kia ora, Kevin. Now, thank you. I'm sure that was heard around the room. Just take a question here, and then I think, was there somebody else just here on the right?
Hello.
Aroha.
Hi, John Chambers from Dunedin, originally from Glasgow in Scotland. I'd just like to ask Dr. Kloiber about something that he didn't comment on, but in your slides, Russia stood out as having an enormous number of doctors per 100,000 population. Perhaps the darkest country on the graph, huge country, was Russia. Now, I think it dates back to 1938, I think, when there was a conference in Geneva about where they debated whether the doctor should be paid per procedure or should be paid a salary. And the Americans won that debate, saying that doctors should be paid per procedure. Because if you were paid a salary, it would be like communist Russia. So in communist Russia, doctors are paid a salary, I understand. And there are huge amounts of doctors in Russia. We live in a country where doctors are paid per procedure, and proceduralists in this country and across the Tasman are decadently wealthy, absolutely, unbelievably wealthy. Yeah. What's medical care like in Russia?
First of all, it's like in every big country. It depends a little bit where you live. And let's speak about the western part of Russia, which is on the west side of the Ural, where you have big cities and centers. And I was amazed. When I was shown to a public clinic in Moscow, completely owned by the state, and it had two entrances. There was one on the left side with a nice glass door and credit card emblems on the door. Nobody standing in front of that door. And there was a right door, which was looking a little bit shabby, I would say, with a long queue in front of that, and a lot of people waiting to get in. In that side, under-equipped, no modern equipment. In the left side, marble floor, super-duper equipment, Western technology. And so my question is, what is this? And I said, is this all publicly owned? I said, yeah, that's all owned by the state. And I said, what is left side and what is right side? Well, left side is for those who can pay, and right side is for those who get the public service. This may answer some of your question there. So if you have money, quite obviously you can get very excellent service. If you don't have, it's a little bit more difficult to get it. Yes, it has improved over the past years significantly in Russia. And the Soviet system has produced a high number of doctors. To me, it was quite interesting to learn about the question of how doctors have been paid. When I was working for the Max Planck Institute for Neurological Research, I was in charge as the youngest assistant there. I was in charge for the cooperation with East Germany, which at that time was still communist. And I was traveling from time to time to East Germany, which was actually more difficult than to come to New Zealand. By the way, it took the same time to go there. Yeah, it was really very, very difficult. I was visiting those houses in East Germany, in cities like Jena and Leipzig, industrial cities there, and most of the houses were really devastated on the inside. The staircases were rotten, the walls were wet, so where normal people would live. And then I was at the home of my colleague, a physician, and his wife, a dentist. Also a house which they didn't own. It was a multi-family home with 6 or 7 families living in that, built in the last century or the 19th century. And I saw this house was well painted, well maintained. It was dry, no luxury, but it was okay. It was good. I mean, it was something which I would have seen in the West. And I said, why is that different? Why is the neighboring house so rotten, and why is it so good? And she said, you know, I'm a dentist. And I said, so what? You don't have a high income. I mean, you have the same income as a factory worker in your, and she was working in a clinic in the size factory, optical factory. I said, how does that work? And I said, when people are coming to me and they need their teeth fixed, I said, what is your job? And they said, well, I'm a painter. And I said, well, I have a problem at home. So you come and paint my walls, and I will fix your teeth. And this kind of trade-in was very normal. And I was wondering why this never has been kind of a question of prosecution. Why in this, and I'm not aware of any case in the whole communist system wherever a physician has been prosecuted for taking this great payment, this under-the-table money or natural things that you could give. And that is that there was an understanding, which is said to be phrased by Lunacharsky, which was one of the political commissioners in the very beginning under Lenin, who said that doctors should not be paid, doctors should be nourished by the community. And so there was a common understanding all those time that it was completely okay that you would give something for your treatment and would get the treatment in reverse in that. And quite obviously that has worked in that system. So that may explain a little bit on how this system had evolved. Nowadays, this is of course no longer acceptable, What we need is a fair payment for doctors where they can live from and can have a decent living from, a fair payment for their service, and not asking for under-table money, because universal health coverage you don't get with that. I think that this will be always an unfair system because it is based then on the ability to give and not on the question, what is your medical need?
Just got a question on the right-hand side with microphone. Yep, and then way on the left, and then in the middle, and that might about take us through to cup of tea time.
Thank you. Brian Craig, retired psychiatrist. I've got a confession and then a question for Dr. Kloiber. The confession is I'm a foreign import, so I am an immigrant and came here from Scotland. And I also work in the mental health system. And as you know, the mental health system has a high proportion of foreign medical graduates. I mean, I think we are over 50%, in fact, so it's higher than the figure you had for specialists in general in New Zealand. Now, unlike some of your colleagues who took early retirement, I took late retirement. And so I was kind of wondering if perhaps a solution to the problem is that more psychiatrists should consider taking late retirement, with appropriate kind of cognitive monitoring and that sort of thing. It might help the problem. I don't know.
I'm pretty much convinced that activity into high age keeps you alive, mentally and physically.
Could I ask the question of Tani? I mean, do ED physicians have a sort of a desire for late retirement, or do you burn out because you're our canaries in the health system?
Well, I think there's good international research. I believe I'm not all over it, but that emergency physicians do have a quite high burnout rate and will often divert out into other areas that are less intense, I guess, in the workload. My own solution to managing this is just working 50%. And actually I find that works well for me, and I suspect that you might get twice as long out of me, maybe.
And can I just say, having done just one evening shift during the RMO industrial strikes in ED, I don't know how you do that job. I do not know how you keep doing that job. Hard job. There's a question over here on the left, and then one here in the middle, and then I think that's a cup of tea time.
I'm Suman from Waikato, one of the psychiatrists in working community. I just wanted to highlight one of the positive aspect of migration is that as somebody has already pointed out earlier, that is not all negative. There are positive aspects to it. It's good for human growth, and we are moving towards global world and sort of universal healthcare system. Like, we are still divided by countries, but ultimately we are looking to take out the inequalities and have a sort of universal healthcare on the planet scale. Now, just like to highlight that some countries, especially I know of India, where more than half of the medical schools are private and is self-funded, and they produce more graduates and specialists than it can ever be absorbed by the Indian health system. So they're producing for the global market and the health industry. So that's another aspect of the thing. It's not about taking things away from poor. Like it's exporting human resources. So it's developing into a different angle from what was held previously. Thank you.
Good. So in what in future would come to be known as the Wellington Declaration, there was a support for a universal global health system.
Again, migration has benefits, and I'm not blaming anybody who has migrated. Myself, I have migrated several times, so there's no doubt about that. I acknowledge the fact that you have a lot of colleges in India which are right now producing for immigration from India into rich countries. That's not a question. That's the case in several other countries as well. However, I would challenge the statement to say that India would not be able to uptake them. I think in India you have a completely unfair distribution of wealth. And if that would be more fair, I think there would be enough resources also to employ more physicians, more specialists, more GPs for the whole of the population in India. So there is another problem which goes more to the social determinants of health than to the healthcare itself. Yeah.
So that's about the geographic distribution within countries and following the money, like slugs in a sort of to the lettuce, whatever. Last question here, and then we'll go and get some lettuce.
Jeff Shaw here again. I'm sorry, I'm probably standing between everyone and afternoon tea. I would like to finish this session on a slightly positive note, but start very negatively. I left when I was a medical student in Wellington. I hated the place so much, I vowed I would never come and serve as a doctor in this city, and I have maintained that promise to myself. The next thing is, I left New Zealand 30 years ago to go to Australia for negative reasons. I hated the environment, I hated all the anti-doctor stuff, and I was there for 8 years. I then came back to get 1/3 of the salary I was actually going to get in Australia to come back to New Zealand, so I actually went against the trends to come back to a poorer country, and I'm grateful for that. But when I reflect on my life, I made all these decisions for negative reasons. And when you make decisions for negative reasons, it doesn't actually cost anything to invest in improving things, so you can stop putting doctors off. And so if you want to grab the low-hanging fruit, and something that ASMS can do, is we can actually look at the things which piss doctors off, which make us burn out, and make us want to leave our jobs or go somewhere else. And we can do something about it to fix it. And I would suggest that if you can't measure it, you can't change it. So we've got to measure the things that piss us off and do something about it.
As usual, pithy and to the point. Perhaps I'd just like to respond. You said to finish on a positive note, Jeff. And could I turn that around to the things that are maybe not so easy to measure, but goodwill. Goodwill to each other, goodwill to those we work with, goodwill to our chief executives, and vice versa. Perhaps encapsulate he taonga ronganui te araha ki he tangata. It is the goodwill to others that is a precious treasure. And we do have that, but I believe, are we using it enough?
That is a very positive note to finish this session on. Kia ora koutou. I just was reflecting, you might have seen me looking at the computer, because it's the 30th anniversary of the ASMS, but it's also pretty close to the 30th anniversary of the Berlin Wall coming down, which I think is in 9th of November or whatever. So, look, I guess, maybe that concludes with an example that through the collective actions of many, great things can be achieved and revolutions can be started. So can I hoa te paki to all of our panel members for that awesome quarter.